Today, we're discussing a class of antibiotics known as aminoglycosides. In this video, we'll cover their mechanism of action, classification, uses, pharmacokinetics, adverse effects, contraindications, and important clinical pearls. What are aminoglycosides? Aminoglycosides are bactericidal antibiotics primarily used to treat serious infections caused by aerobic gram-negative bacteria. They contain amino sugars attached to an aminocyclitol ring through glycosidic bonds, which is why they are called aminoglycosides. These antibiotics are especially valuable in hospital settings for severe infections. Basic structure of aminoglycosides. Aminoglycosides have a characteristic chemical structure that is responsible for their antibacterial activity. As shown in the diagram, the central part of the molecule is the aminocyclitol ring, which serves as the core or backbone of all aminoglycoside antibiotics. Attached to this central ring are one or more amino sugar molecules. These amino sugars surround the central nucleus and contribute to the unique properties of each aminoglycoside. The amino sugars are connected to the aminocyclitol ring through glycosidic bonds, represented by the red oxygen linkages in the diagram. These bonds hold the entire structure together and form the complete aminoglycoside molecule. Another important feature is the presence of multiple amino groups, shown as NH2, and hydroxyl groups, shown as O, throughout the structure. These functional groups make aminoglycosides highly polar and water-soluble. Although all aminoglycosides share the same basic structural arrangement, differences in the number, type, and position of the amino sugars produce different aminoglycoside antibiotics. Therefore, the basic structure of an aminoglycoside can be summarized as aminocyclitol ring plus amino sugars connected by glycosidic bonds. This common structural framework is the hallmark of all aminoglycoside antibiotics. Aminoglycosides can be classified into several important drugs. Streptomycin was the first aminoglycoside discovered and is commonly associated with the treatment of tuberculosis. Neomycin is mainly used topically and for bowel decontamination because of its poor systemic absorption. Kanamycin is an older aminoglycoside that has largely been replaced by newer agents. Gentamicin is one of the most widely used aminoglycosides and is effective against many serious gram-negative infections. Tobramycin has strong activity against Pseudomonas aeruginosa and is frequently used in respiratory infections. Amikacin is a semi-synthetic derivative of kanamycin and remains effective against many resistant bacterial strains. Plasmicin is a newer aminoglycoside developed to combat multi-drug-resistant gram-negative bacteria. These drugs share a similar core structure but differ in their side chains, spectrum of activity, and resistance profiles. Aminoglycosides can be classified according to their clinical use into systemic and topical agents. Systemic aminoglycosides. Systemic aminoglycosides are administered to treat serious infections throughout the body. They are usually given intravenously or intramuscularly because they are poorly absorbed from the gastrointestinal tract. The major systemic aminoglycosides include gentamicin, amikacin, tobramycin, streptomycin, plasmicin. These drugs are commonly used for severe gram-negative infections, septicemia, hospital-acquired pneumonia, complicated urinary tract infections, and other life-threatening bacterial diseases. Topical aminoglycosides. Topical aminoglycosides are applied directly to the skin, eyes, or ears to treat localized infections. The commonly used topical aminoglycosides are neomycin, gentamicin, tobramycin. These agents are frequently found in creams, ointments, eye drops, and ear drops for the treatment of superficial bacterial infections. An important point to remember is that gentamicin and tobramycin can be used both systemically and topically, depending on the clinical condition and route of administration. Aminoglycosides exert their antibacterial effect by inhibiting bacterial protein synthesis. However, unlike many other protein synthesis inhibitors, aminoglycosides are bactericidal, meaning they kill bacteria rather than merely stopping the growth. Let's understand the mechanism step by step. Step 1. Entry into the bacterial cell. First, The aminoglycoside molecule enters the bacterial cell through an oxygen-dependent active transport system. Because this transport requires oxygen, aminoglycosides are ineffective against anaerobic bacteria. Step 2. Binding to the 30S ribosomal subunit. Once inside the cell, the drug binds irreversibly to the 30S subunit of the bacterial ribosome. This binding interferes with normal protein synthesis. Step 3. Misreading of mRNA. The binding causes the ribosome to misread the genetic code carried by messenger RNA, or mRNA. As a result, incorrect amino acids are incorporated into the growing protein chain. Step 4. Production of abnormal proteins. Due to this misreading, bacteria produce abnormal, defective, or non-functional proteins. These faulty proteins are unable to perform their normal cellular functions. Step 5. Damage to the cell membrane. Some of the abnormal proteins become incorporated into the bacterial cell membrane, disrupting its integrity and increasing membrane permeability. This causes leakage of essential cellular contents and further impairs bacterial survival. Step 6. Bacterial cell death. Ultimately, the combined effects of defective protein synthesis and membrane damage lead to irreversible bacterial injury and cell death. Therefore, aminoglycosides are classified as bactericidal antibiotics. Aminoglycosides are primarily active against aerobic gram-negative bacteria and are commonly used to treat serious infections caused by these organisms. Activity against gram-negative bacteria. Aminoglycosides are highly effective against Escherichia coli, E. coli, Klebsiella species, Proteus species, Enterobacter species, Serratia species, Pseudomonas aeruginosa. Because of their potent activity against these pathogens, aminoglycosides are frequently used in severe hospital-acquired infections. Activity against gram-positive bacteria. Aminoglycosides have limited activity against gram-positive organisms when used alone. However, when combined with beta-lactam antibiotics such as penicillins or cephalosporins, they exhibit a synergistic effect against Staphylococcus species, Streptococcus species, Enterococcus species. This combination is commonly used in serious infections such as infective endocarditis. Activity against mycobacteria. Some aminoglycosides, particularly streptomycin and amikacin, are active against certain mycobacterial infections, including tuberculosis. Important limitation. Aminoglycosides are ineffective against anaerobic bacteria because their entry into bacterial cells requires an oxygen-dependent transport mechanism. To use aminoglycosides safely and effectively, it is important to understand their pharmacokinetic properties, including absorption, distribution, metabolism, and excretion. 1. Absorption. Aminoglycosides are poorly absorbed from the gastrointestinal tract due to their highly polar nature. Therefore, for systemic infections, they are usually administered by intravenous, IV, route, intramuscular, IM, route. Oral administration is generally limited to local effects within the intestine, such as bowel sterilization before surgery. 2. Distribution. After absorption, aminoglycosides distribute mainly into the extracellular fluid. They achieve good concentrations in blood, urine, peritoneal fluid, pleural fluid. However, they have poor penetration into cerebrospinal fluid, CSF, eye, prostate, bone. Because of poor CSF penetration, they are not usually the first choice for meningitis. 3. Metabolism. Aminoglycosides undergo minimal or no metabolism in the body. Most of the administered drug remains unchanged. 4. Excretion. Aminoglycosides are eliminated primarily by the kidneys through glomerular filtration. They are excreted in an unchanged form in the urine. Aminoglycosides are primarily used for the treatment of serious and life-threatening bacterial infections, particularly those caused by aerobic gram-negative organisms. 1. Severe gram-negative infections. Aminoglycosides are widely used in septicemia, bloodstream infections, hospital-acquired pneumonia, complicated urinary tract infections, intra-abdominal infections. These infections are often caused by organisms such as E. coli, Klebsiella, and Pseudomonas aeruginosa. 2. Pseudomonas infections gentamicin, tobramycin, and amikacin are particularly effective against Pseudomonas aeruginosa, a common cause of hospital-acquired infections. 3. Tuberculosis. Streptomycin and amikacin may be used as second-line drugs in the treatment of tuberculosis, especially in resistant cases. 4. Plague and tularemia. Streptomycin is considered a drug of choice. 5. Infective endocarditis. Aminoglycosides are used in combination with beta-lactam antibiotics or vancomycin to achieve a synergistic bactericidal effect in infective endocarditis. 6. Bowel preparation before surgery. Oral neomycin is used to reduce intestinal bacterial flora before certain gastrointestinal surgeries. Although aminoglycosides are highly effective antibiotics, the use is limited by several important adverse effects. Therefore, careful monitoring is essential during therapy. 1. Nephrotoxicity. Nephrotoxicity, or kidney damage, is one of the most common adverse effects of aminoglycosides. These drugs can accumulate in the renal cortex and cause injury to the proximal tubular cells. Clinical manifestations include increased serum creatinine, reduced glomerular filtration rate, acute tubular necrosis. The risk increases with high doses, prolonged therapy, pre-existing renal disease. Fortunately, nephrotoxicity is usually reversible if detected early. 2. Ototoxicity. Aminoglycosides can cause damage to the 8th cranial nerve, leading to ototoxicity. This may affect cochlear function, hearing loss, tinnitus, vestibular function, vertigo, dizziness, balance disturbances. Unlike nephrotoxicity, ototoxicity may be irreversible. 3. Neuromuscular blockade. Aminoglycosides can interfere with neuromuscular transmission. This may result in muscle weakness, respiratory depression, paralysis. The risk is higher in patients with myasthenia gravis, Parkinson's disease, those receiving neuromuscular blocking agents. 4. Hypersensitivity reactions. Although uncommon, allergic reactions may occur, including skin rash, fever, pruritus, itching. Contraindications. Aminoglycosides should be avoided or used cautiously in absolute or relative contraindications. Hypersensitivity to aminoglycosides, myasthenia gravis, severe renal impairment, pre-existing hearing loss, vestibular disorders, pregnancy. Use cautiously because fetal ototoxicity can occur. Several drugs can interact with aminoglycosides and increase the risk of serious toxicity. Therefore, these combinations should be used with caution. 1. Increased nephrotoxicity. When aminoglycosides are administered with other nephrotoxic drugs, the risk of kidney damage increases significantly. Important examples include vancomycin, amphotericin B. Patients receiving these combinations should have their renal function monitored regularly. 2. Increased ototoxicity. Certain drugs can enhance the ototoxic effects of aminoglycosides, increasing the risk of hearing loss and vestibular dysfunction. These include furosemide, etoacrinic acid. The combination may result in tinnitus, hearing impairment, vertigo, or balance disturbances. 3. Increased neuromuscular blockade. Aminoglycosides may potentiate neuromuscular blockade when used with general anesthetics, neuromuscular blocking agents. This can lead to excessive muscle weakness, respiratory depression, and, in severe cases, paralysis. Loop diuretics. Understanding these resistance mechanisms is important because they can reduce the effectiveness of treatment and contribute to antibiotic failure. 1. Enzymatic inactivation. The most common mechanism of resistance is enzymatic inactivation. Certain bacteria produce enzymes that chemically modify the aminoglycoside molecule, making it inactive. These enzymes can acetylate the drug, adenylate the drug, phosphorylate the drug. Once modified, the antibiotic can no longer bind effectively to the bacterial ribosome, resulting in loss of activity. 2. Alteration of the ribosomal binding site. Another mechanism involves changes in the bacterial 30S ribosomal subunit. These structural alterations reduce the binding of aminoglycosides to their target site. As a result, protein synthesis is no longer effectively inhibited. 3. Reduced drug uptake. Aminoglycosides require an oxygen-dependent transport system to enter bacterial cells. Some bacteria develop resistance by decreasing drug uptake or reducing membrane permeability. When less drug enters the cell, its antibacterial effect is significantly reduced. Patients receiving aminoglycosides should be monitored carefully to prevent toxicity. Renal function. Monitor serum creatinine, blood urea nitrogen, BUN. This helps detect kidney damage early. Hearing assessment. Monitor for hearing loss, tinnitus, vertigo. These may indicate ototoxicity. Drug levels. Peak levels assess effectiveness. Trough levels assess toxicity. Regular monitoring helps ensure safe and effective aminoglycoside therapy. High-yield exam points. Check mark. Aminoglycosides bind irreversibly to the 30S ribosomal subunit. Check mark. They are bactericidal antibiotics. Check mark. Require oxygen-dependent transport into bacterial cells. Check mark. Ineffective against anaerobes. Check mark. Major toxicities. Nephrotoxicity, ototoxicity, neuromuscular blockade. Check mark. Excreted unchanged through kidneys. Check mark. Gentamicin and streptomycin are commonly tested in pharmacology exams.